Well, thanks, Mike, for the introduction. And as Mike said, I'm going to start screen sharing just to make sure. And I switched my screens around, so hopefully this will be smooth. Can you see the PowerPoint, Mike?
Sorry, I was on mute. Yes, I can see it.
Great. All right, perfect. Okay, so I'm Maureen Kishna, as Mike said. I have been working in MST, multisystemic therapy, for the last 22 and a half years. So that's where my perspective comes from. Although I have worked in, hold on a second. Can I advance the slides? Let me see. Just a second, I'm having some problems advancing the slides. Okay, there we go. So that's where my perspective comes from. But I've also worked in residential treatment, in schools, and community respite camp with kids who have severe behavioral issues and emotional disturbances. So I think a lot of that goes into what I do, but you will see that what I'm presenting today really it comes a lot from my experience in multisystemic therapy, because as I worked in those settings, I really struggled with not being able to get in to work in the home in a really, I just couldn't do any work in the home when I was working in those other settings, and I found it to be extremely frustrating for me because I knew that was where the biggest change could come from. And the other thing I wanted to just say is we typically work with adolescents, so we can work with kids as young as 10 if they're appropriate, and up to 18. But again, my lens is really about working with adolescents. So please think about the kids that you're working with, and of course, tailor anything to be developmentally appropriate. The other thing about working in the standard MST model is that we work with kids that are by and large willfully defiant. They have a lot of co-occurring issues. But if the children that you're working with, if their behavioral issues are really not within their control, like a more typical adolescent is, then these approaches may not be totally appropriate. So I want you to think about the kids that you're working with and making sure that you're tailoring anything I say to be clinically appropriate for the population you're working with. But we believe in MST that if we can improve the family functioning, then we're much more likely to be able to improve the functioning of youth's behavior across multiple systems. And you'll see I pull in different interventions from a wide array of clinical approaches that we utilize in MST, and we always tailor that to what the child's individual assessment indicates is needed. So the other thing I want to say about this is the concept of aggression is big and broad, as you all know. And I felt like I didn't quite do it justice, even the concept of interpersonal aggression, because it's such a short period of time. But some of these strategies are generalizable to kids who engage in self-harm, but not all of it is. But I just didn't think that I could possibly focus on that sufficiently. So just keep that in mind as well. Mostly going to be focusing on aggression towards others. So one of the first things to do is I'm working with families is to help the adults that work with the child to really define what aggression is. I find that it's extremely common for parents to call things aggression that are not actually aggression, whether it's tantruming behaviors or disrespect behaviors. And then oftentimes what ends up happening is the parent kind of over responds to those behaviors. So first thing I do is really try to label really in a behaviorally specific way, what is the aggressive behavior of concern? That in and of itself can be therapeutic for the parents to kind of recognize if the child is not actually aggressive, they're not at risk of harming themselves or others, then that is a whole different kind of level of concerning behaviors. But if aggression is happening by the child towards themselves or others, obviously those safety concerns are obviously going to be the behavior that we're going to want to tackle first. We're really going to want to address that first. So it's not to say that we won't address other behaviors, but a lot of times parents want us to start with disrespect. That's kind of a losing battle because we're not going to be able to get the child's disrespect to change right away. So we have to first set reasonable expectations of what we can address. First priorities, let's make sure everybody's safe. And we want to get a really clear baseline of the types of aggressive behavior the child engages in. We want to, for each of those, we want to get a clear understanding of how often is this behavior happening? How severe does it get? So has the child used weapons? Has the child injured anybody? Is there system involvement because of the child's aggression? How long has this behavior been happening? If it just suddenly started, did something happen to kick this behavior off all of a sudden? All of these assessment pieces are super important to really understand why these behaviors are occurring. And then the other thing is we want to assess, where are these behaviors occurring? Is it only in home, or is it only in the community? Is it only in school? Then that would make me curious about some things. Is it that there's no limits set at home, so there's nothing to get aggressive about? Or is it, where does a child behave really, really well at school? Then why is that? What are the strengths to leverage off of? What does that tell me about how we can proceed and leverage off strengths in the different systems that surround the child? And it's really common to need to do an assessment separately with the adults, because first of all, I want them to be able to talk really honestly with me about what's going on. I used to, for my first phone call with families, I'd say, who should be at the first session? Because it's very, very common in MST that the kids that we're working with it's very common that they engage in violent behaviors. So first priority, I want that parent to feel safe in sessions. So I need to probably get an assessment and start a safety plan with that adult first before I can pull the child in, or else we're just going to have violence in therapy, which is obviously not going to make anybody want to continue with therapy. It's really important as we do the assessment to not engage in anything that would be seen as victim blaming. For adults who have been assaulted by their children in their care, obviously it's a very traumatic, upsetting situation. And so we want to be really, really mindful about that, and non-judgmental. And in particular, if you have a parent that was a victim of domestic violence by that child's other parent, it can be really a sensitive discussion and topic, and we need to handle it with respect, and make sure that the way that we're asking questions is sensitive and caring as it can be, and considerate. One of the things, we want to get a really clear sequence of events of when the child gets aggressive, what happens. And oftentimes parents or adults that are part of a sequence that gets aggressive are really ashamed to talk about their role in the sequence. So I found it's hard to get a good sequence because a lot of times they don't want to tell you about what they did, and that's understandable. So I found it really helpful when I say, like, I need to understand it as if we're watching a scene of a movie. How does it play out? So that you and I can figure out together, is there any way that we might be able to change a part of the sequence to get a different outcome? I don't know. Maybe there is. So it's not saying, oh, I know for sure there's a way to change it. But if we assume a stance of curiosity, it's not saying, oh, you should have had this figured out already. It's more empathetic towards, this is a tough situation. If this child's behavior could change so quickly, you would have already figured it out. I'm here to help you try to figure this out. I usually gather sequences of like really big incidents that have occurred, like if the child was recently arrested, or if somebody was recently sent to the hospital because violence got out of control. I get sequences and then do enough sequences so that I can understand the pattern. So oftentimes I have to really take it slow with gathering the sequence and have people slow down. Let's back up. I don't know how he went from this to this. Tell me, you said that you told him to get up and out of bed. Tell me specifically how you told him to get out of bed and how close were you to him? Again, I need to really see the scene in the movie so you and I can figure out together if there's any way we could change the outcome of the scene in the movie. And we oftentimes do it in pencil. or you can do it in Microsoft Word has like smart art tabs that help you do sequencing blocks that you can use if you're tech savvy. I am definitely not, as my PowerPoint probably indicates. And then you can have them identify what are the choice points, what are things that we could try to do differently to get a different outcome. It's really, really common for people to have, sometimes you have to do the sequences separately. And so it's really important to reiterate, it's not to keep secrets. If there's something important enough to talk about in a sequence, we need to talk about it together. But in order for safety to be assured, you may need to kind of separate people to get the assessment part completed safely. And it's often very common to have some discrepancy between people's version of events. And that's okay. Like, that's normal, right? We process things differently. There might be some shame involved in telling you about the sequence. So we're not going to be confrontational. We're going to be curious, and we're going to see if we can identify areas that we can agree upon, that we can try to see if we can change it so we get a different outcome in the future. It's also really important to remind people, if you're a mandated reporter, which I think probably most of us are on this call, if not all of us, that we let people know before we gather the assessment that what our role is, what does need to be reported. So if something comes up, we learn about from the sequences that the adult was abusive to the child, that we let them know that we will call children's services with them. Ideally, we have the parent or the adult call, and we're there to support them. If that's not something they'll do, if we can call when they're in the room with us, if we're not able to do that because of a time crunch or something, less ideally, we call them and let the family know that we're calling. And then let the children's services know that you're working on developing a safety plan, if in fact that's what your role is. And then if an adult is aggressive as part of the sequence, or if an adult, if an adult is aggressive, which is part of the sequence of violence that occurs, it's important to come up with a safety plan with the parent when they're sober, with the adult when they're sober, when they're clear-headed in advance as to where can the child go. If the parent's upset and the parent's not in a good place to know what's happening or not able to follow the safety plan, let's come upon agreed upon safe adult that the kid can go to, and that the parent knows that's where the child will be when they are more aware of what's happening. So again, we need to identify, once we get the sequences, identify some choice points or things that we could try to do differently to get a different outcome. And we really prioritize an MST focusing on the adult, working with the adult to be able to follow the safety plan, because it's going to take time for our kids to be able to follow it. And most often adults are more developmentally capable because of their brain development and being able to follow plans. So it does take time for our kids to learn to follow plans. Oftentimes, sometimes you have a kid that quickly follows it, but oftentimes if you have a kid with aggressive behaviors, they're not able to follow the safety plan right away in totality. The other thing we need to pay attention to, if you have a kid who has a really high level of aggression, we need to pay attention to and assess privately with the adults if that child has access to weapons or if that child has used weapons, particularly firearms. And it's a really delicate topic, especially nowadays, but we need to figure out how we can best secure, ideally eliminate access to firearms in the homes that the children are staying in. If you have a child who's violent, we know from school shootings, extremely more likely to get the guns in the home of a family than anywhere else. So it can be a delicate topic, but figuring out how best to secure access to weapons is critical. And then also securing things such as kitchen knives and even razors. If the child engages in self-harm, we may need to have the razors locked up and they come get it from the parent when they're calm to shave and then give it back to the parent, those kind of things. And then if at all possible, really avoid putting hands on children. It's understandable that they want to quickly get control, but as we talked about before some people joined, it seems like a helpful thing to do, but generally it's not a helpful way to de-escalate a situation. And then we want to write down, we want to be clear with everybody. Don't follow each other. You know, where are okay places for the kid to exit and wait to? Where can the parent exit and wait to? Don't follow each other. And then make sure we put this all in a written safety plan, have phone numbers on that safety plan, and ideally put those phone numbers of people to call if they need respite, they need the child to go stay with the grandma or something because things are too heated. Make sure everybody has access to those and ideally put those numbers in their phones. Be clear about under what circumstances they call crisis lines, call you, or call law enforcement, which of course we want to really avoid if at all possible. And then there's more advanced skills that you're going to need to work on once that immediate safety plan is in place. Some things to pay attention to, we oftentimes have what we call exit and wait plans. Everybody cool down, right? Because we know how the brain works. We can't think when we're upset and we're really, really escalated. So let's take some time to cool down before we come back together. Make sure that the place where people are cooling down is safe and is okay, and that the parents in agreement. Like, for example, is it okay for the kid to go in the backyard to cool down, or do they run? So is that not okay? And then if you have a child who engages in self-harm, make sure that the parent, even though the parent is not actively engaging with the child because there needs to be cool down, that they are able to keep their eyes on the child and make sure the child's safe. And hopefully the room that they exited to is safety proofed to the best of our ability. Also, you may need to reward siblings for exiting. I know in residential treatment, they always told us, get the least aggressive kids out of the room. And so when people follow the safety plan, they get a certain reward. Try to identify those in advance. There's a lot more strategies that are needed that I have in here in the slide. So when it gets emailed out, you can look at those that are needed after you have the immediate safety plan. But I'm looking at the time, so I don't want to go too much into that because I want to save a few minutes for questions. The one thing before I wrap up, I just want to say it's really important if you're working with a child on safety plan interventions, that every adult who supports that child is aware of it. Because we've definitely had situations where the kid and the family were working on these safety plan interventions that involved exit and wait. And then the kid went to school and tried to exit and wait. And before we know it, we had a school resource officer pursuing them down the hall. Before we knew it, the kid bolted out of the building, and it was like a Benny Hills incident. So making sure that people understand what we're trying to do. And the more that the adult can verbalize what they're doing as part of the safety plan, okay, I need to exit and wait. I need to calm down before I say something I'm going to regret or do something that's unhelpful, the more helpful that's going to be for the child's accelerating their learning. So I just want to stop and ask if anybody, what questions you all have. I know that was a jam-packed slide set, and it's such a in-depth conversation to have, but I wanted to see what questions you have.